Next, we have the lecture by Jastreboff, sir. I would take the privilege to introduce him. Pawel J. Jastreboff is currently the Professor Emeritus of Otolaryngology and Head and Neck Surgery at Emory University School of Medicine, Atlanta, Georgia, and Visiting Professor at University College of London. He is founder and CEO of Jastreboff Hearing Disorder Foundation, where he continues his research on tinnitus and decreased sound tolerance, and provides clinical service to patients with a variety of hearing disorders. He continues to be involved in teaching professionals, including providing intensive courses on management of tinnitus and decreased sound tolerance with tinnitus retraining therapy, and has thus far offered more than 50 courses in USA and over 90 plus internationally. Dr. Jastreboff is recognized for his development of first accepted animal model of tinnitus, the neurophysiological model of tinnitus, and based on it, clinical method of tinnitus and DST treatment known as TRT. Furthermore, collaborating closely with his wife and colleague, Dr. Margaret M. Jastreboff, he proposed a concept, name, and treatment for a specific version of DST, misophonia, when patients exhibit negative reactions to specific for a given patient patterns of sound. Dr. Jastreboff received his PhD in neurophysiology and Doctor of Sciences degree habilitation in neurosciences from the Polish Academy of Science. He did his postdoctoral training at the University of Tokyo, Japan, and has received MBA from Emory University. He has been a visiting professor at the University of Tokyo and Yale University, and adjunct professor at Salus University teaching tinnitus and hyperacusis class in the AUD program. He is co-author of over 140 papers, 180 abstracts, and 3 books. In 1993, he received the prestigious Robert W. Hawks Award for his contribution to the field of tinnitus, and in 2014, at the 11th International Tinnitus Seminar, the Award for Clinical Excellence for 25 years of work of TRT. So with this introduction, I welcome Jastreboff sir to this talk, and it's my proud privilege to introduce him because my work in tinnitus started after I met him in Delhi for his program. I was so impressed that even I shifted my area of focus and I did my PhD also in the area of tinnitus. So with this introduction, I welcome sir to this program and request him to deliver the talk. Thank you.
Well, first of all, I would like to thank you for your kind invitation to take part in your conference, and as well creating opportunity to sharing some of the ideas, thoughts, and results of our work. I have to apologize. The first time I'm using this platform, so I might be a little bit rusty. Let me try to share my presentation with you. Could you see?
It's fine, sir. We can see your slides.
Perfect. Thank you very much. I wasn't sure. Normally I'm using Zoom. So, the subject of this presentation is tinnitus retraining therapy for tinnitus and hyperacusis. And by the way, thank you for such a nice introduction. So, well, what we know for ages, basically, that tinnitus is very popular, affect large proportion of the population, but interestingly, only about 20% of the people who have tinnitus have some problem with this. Additionally, severity of tinnitus and treatment outcome did not depend on psychoacoustic properties of tinnitus, pitch, loudness, match, minimal masking level. And this observation caused that I reach conclusion and propose the neurophysiological model of tinnitus, in which the basic assumption is that in clinically significant tinnitus, the auditory system plays a secondary role and other systems of the brain are dominant. And this was presented in paper in 1990, and around this time, actually in 1988, TRT, first version of TRT was proposed. Now, reaction of a patient indicate that limbic and autonomic nervous system are always involved, practically always involved, in addition to other stem of the brain. And it's because of which type of a reaction patient are experiencing. What's interesting and important to remember that this reaction, like annoyance, anxiety, panic, problem with concentration, decreased ability to enjoy life activities, sleep difficulties, depression, impaired concentration, irritability, are observed not only in tinnitus, but in any case when the sympathetic part of autonomic nervous system is overstimulated. Please remember this, I'll be returning to this again. Now, having this in mind, how we may try to treat tinnitus. In this case, the treatment is aimed on retraining connection of its auditory system with other stem of the brain to achieve habituation of negative reaction to tinnitus, and this is primary goal of TRT, and then habituation of tinnitus perception, which occurs automatically once sufficient level of habituation of reaction is achieved. In this case, brain plasticity is crucial for retraining and habituation. So you have an auditory system and you have a limbic system somewhere here in the base of the brain, and here we have a block diagram, which is known as a block diagram of the model. In case of a person experiencing tinnitus, with 80% or so people with tinnitus, only auditory system is involved. And we have a perception, we have some evaluation, but the tinnitus signal, tinnitus-related neuronal activity, which is perceived as a tinnitus, is not spreading to limbic and autonomic nervous system. Person is experiencing tinnitus, but not suffering because of it. Problem starts when this tinnitus signal starts activating limbic and autonomic nervous system. And what is important to remember that there is a very strong connection, which we very well know from neuroscience, between medial geniculate body and lateral ventral nucleus of amygdala, this arrow, which is causing the tinnitus signal can and is stimulating our limbic system at subconscious level. I will be returning to this point and showing results supporting this postulate. Additionally, we know that from other part of amygdala is a very strong connection to inferior colliculus, which cause that depending on the mood and emotional status, exactly the same activity within auditory system is processed differently. So we have a additionally vicious cycle, which is causing that subconscious signal of tinnitus is causing negative emotion, which in turn are enhancing this signal. There is, of course, connection from the conscious part, but this connection marked here in red seems to be dominant. So, what TRT is aimed to treat? We know that auditory system is definitely involved in mechanism of tinnitus, and very frequently we're observing hearing loss. Actually, in about 80% of tinnitus patients have some degree of hearing loss. There is a very popular decreased sound tolerance in about 60% of cases. So it's not only tinnitus which is creating a problem. And what model is postulated in TRT, it is necessary to take into consideration these problems to achieve successful outcome of tinnitus treatment. In other words, if patient is above tinnitus and decreased sound tolerance, it is necessary to have a sufficiently high chance of achieving improvement in tinnitus to address and to work on removing decreased sound tolerance as well. Now, tinnitus retraining therapy, the name is coined ages ago, and just to stress retraining part. It's not only on tinnitus, even tinnitus was in the name, it was for just having short name, but from the very beginning, treatment of hearing loss and decreased sound tolerance were included in tinnitus retraining therapy. So what is TRT? This method is aimed on decreasing, which is method aimed at habituation of negative reaction or decreased sound tolerance. The goal is to achieve situation when patient still perceives tinnitus, but she is not bothered by it in most of the time and can live normal life. And by the way, perception of tinnitus, because of automatic happening, habituation of perception, is as well pretty high, and typically patients at the end of the treatment are perceiving tinnitus 10-20% of the time, and even then it's not bothering them. So we have an automatic habituation of perception, and it's not goal. It will be not actually correct, it will be counterproductive, trying to achieve habituation of perception first and reaction second. So we have an extinction of subconscious condition reflexes. The model postulating that the main problem is in existence of a subconscious condition reflexes connecting auditory system with limbic autonomic nervous system. And dominant group of the one which is conscious and the other subconscious seems to be subconscious part. It's very important, and I'm afraid not sufficient to recognize, but since treatment is aimed to work above on the side, if you will, of tinnitus source, there is the etiology of tinnitus is irrelevant. And from my 30 years of practice with tinnitus patient, at nicely over 2,000 patients, I haven't noticed any impact of what caused tinnitus. It doesn't matter, it's noise-induced, or ototoxic drug, or whatever else. And I realize that in this respect, I differ from many specialists who are trying to subdivide tinnitus and subdivide treatment to the type of tinnitus. TRT consists of counseling and sound therapy, which are both based on the model. The main goal, although not the only one, of the counseling, retraining counseling, is reclassifying tinnitus to category of neutral stimuli, while sound therapy decreased strength of tinnitus-related neuronal activity. So, habituation of reaction. This diagram which I show you, it means that the connection between auditory system and both at subconscious and conscious level are broken, are removed, so there are no reactions, even there is perception. And again, then once we get at this partial habituation of reaction, habituation of perception occurs automatically, and patients are aware of tinnitus more and smaller perception proportion over time. Now, it's worth mentioning mechanisms of hyperacusis. We have Margaret will be delivering special lecture about mainly misophonia, but hyperacusis as well. And I would like to point your attention that in case of a hyperacusis, we have interesting both human and animal data showing that hyperacusis is due to the over-amplification of signal occurring at subconscious part of auditory pathway, that's in this red oval. So on this diagram, it will be potential in the cochlea, but practically we're not seeing peripheral mechanism of hyperacusis, but at subcortical level, signal is enhanced and in turn is causing overexcitation of limbic autonomic nervous system. All of these connections are normal. This is a main source of a problem. Now, I mentioned to you about the subconscious pathways. Processing information, any kind, at subconscious level plays actually significant role in learning and necessarily many other aspects of life. And it's incorrect to assume that if you are not perceiving something, it's not, you cannot train brain or change this. Actually, reflex reaction learning can occur without the conscious perception of stimulus. It's a big literature on this, including brain imaging and so on. Just to test this, I analyzed data from 303 patients, which were evaluated and treated in the same way, and trying to predict severity of tinnitus. And I was using tinnitus handicap inventory, which I believe is probably, together with the tinnitus function index, the best way of assessing tinnitus severity, and is widely popular and recognized, validated, and so on. So the goal was, is it possible to predict, and how well predict, severity of tinnitus using different parameters of different measure of tinnitus on different scale? It's a problem, percent of annoyance, percent of awareness, and so on. And what is interesting, first of all, the model turned out to be extremely accurate. That means it was possible to predict over close to 80% of the variability using this model, which for biological medical data is extremely high. But what was most interesting, the percentage of the time when patients were annoyed by tinnitus and loudness, subjectively judged loudness of tinnitus, were totally, absolutely irrelevant. Now, if perception of tinnitus and involvement of a higher loop, conscious loop, was dominant or was important, those two factors should have a high level of contribution or significance. They're absolutely not significant. So this is showing that subconscious pathway plays dominant role for tinnitus severity in case of a chronic tinnitus. In case of acute tinnitus, conscious pathways plays a little bit larger role. And as a consequence, even when patients are not aware of tinnitus, they still can be affected by it. You can think about this like if subject is dehydrated. In my experience, vestibular problem or hearing problem or so, without realizing why and what. And it's not necessary to think about this, and patient may have even no idea what's going on, but will be feeling not well. The same tinnitus can affect a patient even when patient is not aware of its presence in a given moment. And second consequence, but if you are going to treat tinnitus, the treatment should incorporate the extension of subconscious condition reflexes. So not only thinking about tinnitus, but what's going on at subconscious level. And TRT is doing exactly this. So in these two paths, conscious, including thinking, evaluating, perception, and the other one, subconscious, this subconscious loop seems to be dominant in chronic tinnitus. And TRT is aimed at removing these connections, which seems to be most important. So, TRT includes component aimed at rectification of changing of this malfunction of value system of the brain related to tinnitus, misophonia, sleep, and so on and so forth. Subconscious part of the brain plays dominant role, so treatment should include this method which aims at subconscious level. And conscious cognitive system are particularly important in the initial stage of tinnitus and misophonia. Later on, they still play a role, but became dominated by subconscious level. And since retraining of conscious level is easier, for example, CBT is lovely for this goal, acute tinnitus or misophonia, which direction below approximately 3 months, is easier to treat. Condition reflexes. Well, I don't have to give a lecture of condition reflexes, but I would like to point out few main features which are relevant in this case. In case of a condition reflex, we are observing proper reaction but to improper stimulus. Patient is reacting to benign stimulus, like if it's a life-threatening stimulus, because of its inappropriate judgment made by subconscious part of the brain. At the same time, we know that not only each, but any condition reflex can be reversed and retrained by proper technique, but those are techniques which are proper to condition reflexes. And habituation of reaction and perception can be achieved. What TRT is using, among other things, is modified Pavlov method of passive extinction of condition reflexes by decreasing strength of negative reinforcement. In this case, it's activity of autonomic nervous system, and strength of conditioned stimulus, that means strength of a tinnitus signal at the same time. And please note that in this concept and what you're observing, the limbic and autonomic nervous system are within the norm, but the reflex-based reaction occur to stimulus which should not cause the activation. So the stress is on the inappropriate created and enhanced function connection between auditory system and other system of the brain. Again, condition reflex, if we have an external signal sound, in case of misophonia or tinnitus, in case of a tinnitus, which is perceived, but in the same time we have a reinforcement, something that is happening or people are feeling incorrectly, we are getting reaction, negative reaction. In this case of tinnitus, it's an enhanced activation of sympathetic part of autonomic nervous system. So when tinnitus is present, you don't need to have these reinforcements to still have a reaction. And this is a crucial feature of condition reflexes. Now we know that every reflex undergoes extinction, but simply it's not so easy to achieve in case of a tinnitus because this negative reinforcement in case of tinnitus, this punishment, is actually activation of autonomic nervous system, so this reflex is self-enhancing. And this extinction is called passive extinction of condition reflexes or habituation of reaction. There are two terms describing the same process. Now, tinnitus can acquire negative association through a number of features, even prolonged continuous presence of neutral stimulus can be irritating and creating problem. Fear of new unknown danger, but most common is negative counseling. It's all around the world that patients are being told nothing can be done, you will have tinnitus up to end of your life, and just in case, let's do the brain scan to check if you have a brain tumor. This is causing significant worsening and enhancing of this reflex, which is much more difficult to remove. So we have a habituation of reaction, habituation of perception, as I mentioned, and I would like to point out that habituation as a process is integral and necessary function of the nervous system. The trick is to retrain the brain and push the brain into habituation of tinnitus signal. Brain is doing it wonderfully for majority of the signals, sensory signal happening around us. So as I mentioned previously, because in case of a tinnitus, this reinforcement is activation of the autonomic nervous system. It's a self-reinforcing situation, and because of this, automatic, spontaneous habituation of tinnitus is basically observed very, very rarely, and is not playing significant role in tinnitus treatment. Now, you have a certain stages of tinnitus TRT implementation, and I'll be going into a little bit more detail for all of this, but we have initial contact, initial interview, audiological evaluation, medical evaluation, diagnosis, and assigning proper category of the patient, retraining counseling, sound therapy, which involves heavy part of counseling, and fitting instrumentation if needed, and series of follow-up visit of main role of counseling and following audiological evaluation. So in initial interview, we are listening to patient description of problem history, which is very useful to pick up the points which are most important to be addressed during counseling. Using questionnaire is crucial, and it is necessary to use the specific tinnitus-oriented questionnaire as THI or TFI. The issue was studied by biostatistician from NIH, National Institute of Health, and the verdict was that using just quality of life or change of anxiety or so is inappropriate in case of a tinnitus. It's necessary to use specific to tinnitus questionnaire. And structured interview, going through a number of a question, systematic question, which are asked in the same way to all patients, so it's possible to compare the results to make some sense out of this. For the structure interview, I was in different form. This is one of the old form, and we have the administrative part about tinnitus, about sound tolerance, about hearing loss, main problem, recommendation, and we have a legend how to ask the question. In audiological evaluation, it's routine audiological testing, but was stressing the audiogram should be done up to 12 kilohertz. Actually, in our clinic, we are doing this up to 20 kilohertz, and it's very, very useful in case of a tinnitus, but even more in case of misophonia, speech discrimination, and so on. Now, specific tinnitus testing, pitch, loudness, match, minimal masking level, distortion product of acoustic emission. From this set, practically loudness discomfort levels are crucial and very important in case of a decreased sound tolerance, and distortion product of acoustic emission is very helpful in diagnosis, in counseling tinnitus patient when discordant dysfunction theory is used to explain where tinnitus is coming from. I will be not discussing this because of a time limit. And additional tests if indicated. In medical evaluation, the goal is to find out if there are any problem which contribute to tinnitus. And in practical terms, out of this, as I told you, more than 2,000 patients, less than 1% of the patients have a medical problem linked to tinnitus, which could and should be treated medical or surgically. It's essential to have statement of clean bill of health as far as tinnitus is concerned from a physician. Because one of the problems is that TRT is so powerful and effective that if, for example, the patient has a vestibular schwannoma, it can be treated successfully, tinnitus ceases to be a problem, and schwannoma will be still growing. So it's important to exclude these few, very few, and very rare cases, but still existing. And if needed, referrals should be made to our professionals. And in our experience, in about less than 5% of a patient, it is necessary to refer patient to have a psychological or psychiatric treatment. We have cases including full bipolar disorder and so on, but they are very infrequent, and in 95% of the cases, it is not necessary, at least in our population of a patient, refer them for psychological or psychiatric treatment. Some patients are coming already and being treated along these lines, but this is in case when typically when tinnitus is not inducing those problems. So patient frequently can very nicely distinguish between having depression for last 20 years without any problem, or having a problem, but having for 20 years, and then after getting tinnitus, getting another level of depression, anxiety, and so on. And TRT can treat and TRT can treat this part of depression or anxiety linked to tinnitus, but obviously not other part. I'm sorry, I'm getting requests for annotation. How can I get out of this? Because I cannot move slides. So how can I block it?
Pardon, sir?
I got somehow annotation. Now I can put slides. How can I block this annotation?
You can click the second option, sir. On the right side, whatever option come, you can click that. Cancel it will come. You can just click cancel.
Where's the cancel?
The cancel annotations, you can just click cancel, sir.
Thank you very much.
Okay.
I told you I'm not familiar with this platform. Great. So next stage, diagnosis and categorization. For this, it's important to recognize impact of tinnitus on life, presence of hyperacusis, impact of hearing loss on patient life, and prolonged sound-induced worsening of tinnitus and hyperacusis. And we have 5 categories of, depending on the hearing loss, tinnitus, hearing loss, impact on life, hyperacusis, prolonged worsening. I'm not going into details into this, but what is important that to assess which category of patient is, mainly to avoid making mistakes. Note, please, that when hyperacusis is present during the initial stage of a treatment, the stress plays on hyperacusis. Other problems are treated at the same time, but with a stress on hyperacusis. Note as well that misophonia is not affecting categorization and is treated concurrently. All patients are advised to avoid silence and avoid overprotection of their hearing. In retraining counseling, the first appointment is very important, extremely important, and as I mentioned previously, aims at the reclassification of tinnitus into category of neutral stimuli, demystify tinnitus, and providing a new frame of reference what tinnitus is about, and removing many concerns and fears, and provides information of mechanisms of tinnitus and misophonia, hyperacusis, and what are mechanisms, what are bases of a treatment. So in this case, TRT is aiming at working with the patient as a partner. The patient needs to understand as much as possible what's going on and which mechanisms can be used for treatment. And we are heavily using real-life examples. Retraining counseling in case of a hyperacusis is stress on sound therapy, presenting concept of automatic gain control, and so on, which all of these parts Margaret will be discussing later. In sound therapy, frequently instrumentation I use, but what's the most important? You can do TRT without any ear-level instruments, but it's stress on decreased contrast between tinnitus and background neuronal activity, background sound, and reduce abnormal gain in auditory system. It's important in case of hyperacusis, and I mentioned it previously. Now, what's the main principle of sound therapy in TRT? The strength of any signal in nervous system, including tinnitus, depends on the difference of a signal with the background neural activity. In case of auditory system, background sound is controlling it. So, we cannot suppress tinnitus by increasing background sound. By increasing background neural activity, and tinnitus signal becomes weaker and is easier to control. It's easier to be controlled by brain. At the same time, masking, total covering tinnitus perception, is counterproductive because brain cannot get retrained on something which brain cannot detect. It's like trying to teach dog to jump, saying well jump, but at the same time playing very loud music. Poor dog will never learn. But short period of masking was nothing wrong with this, just simply you are losing this time from the training. Its sound level is determined by, first of all, by annoyance. In past, we were promoting idea of mixing point, but it turned out that the annoyance level was coming first, and patient were unable to use this, get to this mixing point. We have an intensity of a sound in dBSL above the threshold of hearing with sound, for example, for sound generator, and effectiveness of habituation, we're getting this curve. And due to stochastic resonance, actually for low level of a sound, from our measurement up to 6 dBSL, actually tinnitus signal is getting enhanced. So using device at the threshold of hearing is actually making situation worse. And again, annoyance is crucial level, a crucial point. So we're trying to be somewhere here, and device allow us to be consistently close to annoyance level, but not above this. Sound therapy. So decrease contrast, make more difficult for brain to detect tinnitus, reduce abnormal gain, increase frequency range of stimulation of auditory system. This is issue of in case of a hearing case. It's important to preserve or restore symmetry of stimulation of auditory system, improve communication, decrease strain to hear, decrease focus on ear and sound perception, increase patient sense of control, and decrease general stress caused by tinnitus, misophonia, hyperacusis. I'll be not going into the detail, but each of us is an interesting subject. Now, you can provide enhanced sound background on many devices. Currently, different apps became popular and used by many patients. And can be just normal sound from environment, which is not amplified, but in case of a hearing, amplification by hearing aid or combination device is very helpful. Sound generator or sound generator part of combination devices can play very important role and can be indeed very useful. Why use ear-level instruments, you may ask? In principle, it's not necessary, but it facilitates implementation of sound therapy. It makes it easier for patients, so better following using it. Give patients sense of control, which is quite important as well. Treat hyperacusis, and decrease strength to hear phenomenon in patient with hearing loss. General rules for choosing instruments. In case of a category 0, recent tinnitus or tinnitus is not significant concern, it's not necessary to use any kind of instrumentation, ear-level instrumentation, I mean, we're still using tabletop sound machine, but still can be used, and many patients are using this. With tinnitus, no hearing loss, sound generator. Bothersome tinnitus and hearing loss, combination instrument or hearing case. Now, typically combination instrument. Hyperacusis, sound generator. Hyperacusis tinnitus, sound generators. But you have a hearing loss as well, combination instrument. And always use binaural fitting to preserve, restore symmetry of stimulation of the auditory system. So follow-up visit. Main point is to continuation of counseling. Of course, you are monitoring treatment outcome and so on and so forth. All these points listed here are important, but continuation of counseling is a main role of follow-up appointments, and they are very important to achieve effectiveness treatment. Now, final goals that we have the tinnitus have no impact on patient life. And tinnitus may remain unchanged, but will not induce negative reaction. Example, refrigerator in the kitchen. It's important that patient have a realistic expectation. It's not expecting cure, that means disappearance, tinnitus forever, and so on. For hyperacusis, normal level of tolerance, misophonia, It's actual over 150 now publication in Medline for tinnitus retraining therapy. And it's important to, now I'll be showing you a result of a most interesting studies for TRT and CBT. So, please note that it has been studied and evaluated that tinnitus severity needs to decrease in this standardized questionnaire at a certain level to be approved as a significant. So in case of a THI, it's a requirement to decrease by 20 points, in TFI 13 points, to be clinically significant. Please note that clinically significant improvement on questionnaire needs to be statistically significant, but, there's a big but, statistically significant improvement alone is not sufficient to claim clinically significant results. The bottom line is that if, imagine that on the scale from on THI from 0 to 100, we have a decrease of 5 points, which is not sufficient to claim clinical improvement. But if you have 500 patients, then, and in each patient you have a small improvement, this improvement will turn out to be, this change, not improvement, will turn out to be statistically significant, highly statistically significant. If you imagine each patient or majority have this 5 points. But from clinical point of view, from point of view of patient, it will be totally irrelevant. And this is one of the problem, for example, in transcranial medical magnetic stimulation. There is some improvement, but is too small to reach clinical significance. We have 150 publication Medline for tinnitus retraining therapy, and majority of them are, a vast majority are highly positive. And as I mentioned, from the study, it's interesting to see Henry's study, which was the first valid study showing impact of tinnitus masking and TRT on tinnitus, and it showed, other studies will show success rate around 80% from 70 to 90. And TRT appears to have a significant improvement in about 85% of cases of hyperacusis and misophonia. So main results which I would like to mention briefly. This Henry study, which is on TRT, study published by Simad Aberdeen Lancet, which is a CBT study, and some of our results published in the different books, conferences, and so on. I would like to point out that in case of a Lancet study, which was very nice, that authors used THI, so it was the same as Henry, it was possible to compare head-to-head those two studies. So Henry, TRT. We have a normal TRT. Dr. Henry went through our training course using original version. And treatment which he calls masking, but it was actually our, I think it's a more adequate name, sound relief therapy. Set sound on comfortable level aimed at immediate perception of some relief, masking if possible. So it's different from classical masking as defined by Vernon. This was minimal counseling, however, introducing a recommendation to science, which was actually introduced and was a crucial element of TRT. So if you look at the mean TRT score over the time up to 18 months, you see that in case of a relief therapy, you have some improvement, which just flattened after about 6 months. In case of TRT, you have a significant improvement, getting to 30-point difference. And the same percentage of subjects showing overall improvement is systematically increasing in case of a TRT, and is basically flat in case of a masking. What was very interesting, the authors divide the group of tinnitus into the group which has a moderate problem, big problem, and very big problem. The same for masking and retraining therapy, and analyze after 3, 6, 12, and 18 months. We used effect size, which should be around 0.7 or so to be considered to be significant. And as you see, for moderate problem, it was below level of improvement. For big problem, yes, it was definitely significant improvement. And for very big problem, results were mixed. Results for TRT was quite different. As you see, first of all, it's a systematical improvement with time, which indicates that the treatment is doing something. It's not just, like in this case, working more or less in random. Second, even the moderate problem after 18 months, effect size was about 1.3, 1.2, so it was extremely high. But for very big problem, catastrophic tinnitus, improvement was above, effect size was above 2. So it seems that TRT is effective for any level of severity of tinnitus, but is extremely effective for severe cases which patients have a biggest problem. Now, in case of this Lancet paper with a CBT, 492 patients, very big group patient, treated for 8 months and re-evaluate after 12 months. Main group CBT, control group with standard of care approach, including full audiology, use of ear level instruments, and general counseling. So the difference was mainly that was different kind of counseling. And now, since, as I mentioned, we have a THI used for both Henry and Lancet group, it's possible to compare it directly. Henry group are just with purple lines, CBT green, and as just for comparison, our result from our center in blue. So, in case of a CBT, there is a clear improvement of 12 points. It's not reaching with 20 points line, which is required for clinical significance, but definitely is something. But please notice at the same time that Henry group with an extremely basic use of a sound, just use the sounds which is giving you feeling of some relief, was as effective as CBT. And use control group in CBT was showing improvement on average only 5 points. In case of a TRT, the improvement was, as you saw on our graph, gradually improving the time and reaching 30 points, so nicely above required 20-point minimal improvement. Our results are similar to the Henry point. The Henry results are just a little bit faster, which might reflect the fact that we have a group with a patient with hearing loss and tinnitus, and using combination instrument of this group is providing very fast improvement. So basically after 1 month, you are seeing clear improvement, and after 3 months, it's reaching level of significance. I would like to mention that we have as well something phenomenon which I labeled total habituation of tinnitus perception. It turned out that some patients have a period of time when they cannot hear their tinnitus even if they are focusing their attention on it. I'm one of those patients too. And triggered by this observation, I did a study with Jackie Sheldrake in London on 159 patients, and it turned out that close to 20% of all patients experience this total habituation of tinnitus perception with an average time of 10.5 days, can be from few hours to few months. So in summary, main points is that THI in all the visual analog scales show improvement after treatment lasting 3 months or longer. In case of a DST, we have 85% of improvement, and in many patients it's possible to achieve cure for both hyperoxia and misophonia. And Margaret will be talking more about this. Result cannot be explained by placebo effect, and as you saw, the effectiveness of TRT as compared with CBT is about 3 times better. CBT is definitely working, but it seems that TRT is much, much more effective. And detailed interview and classification of a patient, proper classification, is crucial to achieve improvement. From the take-home points, I would like to point out: avoid negative counseling, avoid silence, never use as a part of sound therapy a sound which would evoke annoyance, discomfort, or any type of a problem. And there is a need to properly diagnose hyperesthmia, as the treatments are distinctly different. And it's the subject of the next lecture. Very briefly, to show what's the heart of a TRT. We have a tinnitus and we have a reaction induced by tinnitus, always negative reaction. Methods such as electrical stimulation of cochlea and sound therapies, which are working on basically trying to some tinnitus signal, were not shown to be as effective. Other group of treatment is a psychological treatment, medication aimed at limit autonomic nervous system, antidepressants, are working on the reaction, improving coping. What TRT is doing, the TRT is trying to go into the mechanism, main mechanism of this connection. So if we block, if we remove connection between tinnitus reaction obviously disappear. So this is heart of TRT. Blocking spreading of tinnitus signal to other part of the brain. Thank you very much for your attention, and I'll be happy to answer any question you might have.